Welcome to the Anesthesia and Perioperative Medicine channel.
So, picture this. You're standing outside the OR, the clock is ticking, and someone hands you this thick, multi-page pediatric echo report. And you know, deep down, that buried in all that jargon are the absolute keys to keeping this child safe. But you've got maybe minutes to figure it all out. Well, today, we're going to turn that moment of pressure into a moment of pure confidence. We're going to build a framework so you can look at any report, no matter how complex, and know exactly what you're dealing with and what you need to do.
All right, here's our game plan for today. First, we're going to talk about why this is such a unique challenge for us. Then we'll dive into the fundamentals of congenital heart disease, really get the why behind what we see on the report. After that, we'll build a step-by-step system for reading any echo report. We'll put that system to the test with some key pathologies, do a really deep dive into a super complex case, hypoplastic left heart syndrome, and then wrap it all up with the key takeaways you can use on your very next shift. Let's get into it.
Look, as anesthesiologists, physiology is our playground. We live and breathe hemodynamics. But let's be honest, taking a specialized pediatric echo report for a kid with a really complex heart and turning it into a concrete plan, that's a whole different level of skill. It's not just about knowing the numbers. It's about being able to visualize this dynamic, three-dimensional system that, well, it often looks nothing like the textbooks. And you have to do it fast. That's the skill we're sharpening today. So before we can even start to interpret the what of an echo report, we absolutely have to lock down the why. I'm talking about the underlying pathophysiology of these defects. This isn't just some academic exercise. This knowledge is the foundation you're going to build your entire anesthetic plan on. This is where we learn the rules of the road for these completely unique circulatory systems. So at its most basic level, what is a congenital heart defect? Really, it's a plumbing problem. It's a structural issue, something that's been there from birth that makes blood flow in ways it was never, ever supposed to. Our job as anesthesiologists is to become the absolute experts on this new, custom-built circulatory roadmap so we can navigate the perioperative period without a single miss. Now, this slide might look simple, but it illustrates probably the single most important principle for understanding the vast majority of these defects, especially the shunts. It's this. The left side of the heart is a high-pressure system. It's built like a bodybuilder to pump blood against the high resistance of the entire body. The right side? It's a low-pressure system. It only has to pump blood next door to the low-resistance lungs. And blood, just like water, always flows downhill, from high pressure to low pressure. That one simple fact of physics determines which way blood will flow through any hole in the heart. So with that pressure principle in mind, we can group pretty much all of these super complex defects into three main physiological buckets. First up, you've got your left to right shunts. This is where that high-pressure oxygenated blood from the left side takes a shortcut through a hole over to the lower pressure right side. What's the result? Well, the lungs get flooded with way too much blood flow. Second, you have right to left shunts. Here, something, usually a blockage downstream, is forcing that deoxygenated blue blood to cross over to the left side, completely bypassing the lungs and making the patient cyanotic. And finally, you have obstructive defects. These are just what they sound like, blockages. A tight valve, a narrowed vessel. It's like a dam in a river, and it creates a huge pressure backup behind it. And this table is fantastic because it shows exactly how that core problem directly dictates what our primary goal is as anesthesiologists. Let's look at that top row for left to right shunts, like a VSD or PDA. The problem is volume overload in the lungs, so our job is to balance the systemic and pulmonary vascular resistance, the SVR and the PVR. Think of it like a fork in a river with two paths. We have to carefully manage how much flow goes down each path. If we drop the SVR too much with our anesthetic drugs, we're basically opening up the highway to the body, which can actually reduce the problematic shunt to the lungs. It's a delicate balancing act. Now look at the right to left shunts, like tetralogy of Fallot. Here, the big problem is deoxygenated blood getting to the body, so our primary goal is to maintain SVR. Any drop in SVR makes the body an easier path for that blue blood, which makes the shunt worse and the patient more cyanotic. And finally, for those obstructive lesions, it's all about pressure and flow. We have to do everything we can to maintain blood pressure after that blockage. Okay, fundamentals are down, now for the main event. We are going to build a methodical, repeatable system for dissecting any pediatric echo report. And I don't mean just skipping to the summary at the end. This is the tool that will let you build your own rock-solid mental model of that child's heart, from the ground up, every single time. And here it is, your 10-step framework. Think of it as your pre-flight checklist. We start with the basics. But let me be 100% clear about this. Step 2, establishing cardiac position in situs, is non-negotiable. It is the absolute,
most critical first step in your analysis. Before you look at a single valve, before you check a pressure gradient, you have to understand the fundamental layout of that heart, because every other piece of information in that report is seen through the lens of situs.
And hey, don't just take my word for it. This is the universal approach. Every pediatric cardiologist will tell you the exact same thing. You have to establish the basic arrangement, the situs, before you can possibly understand the function or dysfunction of all the other parts. It's like you'd need to know if you were looking at a map of North America or a map of Europe before you could even begin to try and find a specific city, right? Situs is your continental map.
So how does situs show up in the report? Well, you're usually going to see it written in this XYZ format. Let's break it down. The first letter, X, is for atrial situs. S stands for solidus, which is normal, right atrium on the right. I is for inversus, which is a total mirror image. The second letter, Y, is for the ventricular loop. This tells you how the heart tube bent when it was developing. D for D loop is a normal rightward bend. An L loop is an abnormal leftward bend. And that third letter, Z, describes the great arteries. S for solidus means they have that normal crisscross relationship. D or L malposition tells you they're in an abnormal spot. So, a completely normal heart is SDS. Any other combination is an immediate red flag that you are dealing with a fundamentally different and way more complex circulatory map.
And this isn't just an anatomical curiosity. Situs lacinta is the architectural blueprint of that kid's heart. It tells you which ventricle is doing which job and how the great vessels are hooked up. For example, if you have a patient with an L loop, the ventricle that looks like a right ventricle might actually be the one pumping blood to the whole body. That ventricle was never designed for that kind of high-pressure work, and it's super prone to failure. Not knowing that basic fact is like flying blind. You have to know the blueprint first.
All right, we have our framework. Now it's time to put it to the test. We're going to apply this systematic approach to a few of the most critical pathologies you're going to see, and we'll translate those echo findings directly into anesthetic implications. So let's kick it off with a true classic, one you will absolutely see in your practice, tetralogy of Fallot. It's the most common cyanotic heart defect out there, and it's defined by 4 very specific anatomical features that all stem from one little error in development. It is a fascinating and super challenging case, so let's really break this one down. Okay, so you pop open the echo report for a TOF patient. Here's what you're going to find using our system. Under ventricles, you'll see a big VSD and a thickened right ventricle. That's RVH. Under outflow tracts, you get the 2 defining features, an overriding aorta, which means it's sitting right over that VSD, and, most importantly, pulmonary stenosis. This is a major blockage to blood flow trying to get to the lungs, often called RVOTO, for right ventricular outflow tract obstruction. The Doppler data then ties it all together. It'll show that the RV pressure is just as high as the systemic pressure, and the shunt across that VSD is flowing right to left. And that, right there, is why the patient is blue. So how does all that translate into our anesthetic plan? Well, in tetralogy of Fallot, absolutely everything hinges on the balance between that fixed pulmonary blockage, the RVO2, and the systemic vascular resistance. If our anesthetic drugs cause the SVR to drop, that right ventricle is suddenly going to find it way easier to just eject blue blood across the VSD into the aorta, instead of fighting to push it through that tight pulmonary valve. This sudden increase in right-to-left shunting is what we call a hypercyanotic event, or a TET spell. To make matters worse, that obstruction, the RVO2, can actually get dynamically worse. The muscle can spasm and clamp down. So our entire anesthetic plan is designed to maintain SVR and avoid this downward spiral. We keep phenylephrine right at our fingertips. We choose anesthetic agents that are known to preserve SVR. And we have a clear crisis plan for a TET spell. 100% oxygen, give fluids, crank up the SVR with phenylephrine, and maybe even use a beta blocker to help relax that muscle spasm.
All right, let's switch gears to a totally different but just as critical neonatal condition, DTGA, or dextrotransposition of the great arteries. In a newborn, this isn't just urgent, it's a true surgical emergency. The echo report in DTGA describes one of the most bizarre plumbing arrangements you can imagine. 2 completely separate parallel circuits. I want you to picture 2 one-way highways that never, ever intersect. The aorta comes off the right ventricle, so it sends blue blood from the body right back out to the body. And the pulmonary artery comes off the left ventricle, sending red blood from the lungs right back to the lungs. The only way this baby survives is through mixing points, little spots where traffic can cross between these 2 highways, usually a hole called the PFO or a vessel called the PDA. The report will confirm this, and it'll tell you that the right ventricle is now the systemic, high-pressure.
So given this bizarre physiology, our entire anesthetic plan is about one thing: keeping those mixing points open. A prostaglandin infusion, PGE1, is literally life-saving because it keeps that PDA from closing. Our job in the operating room is to support the function of that systemic right ventricle, which is really struggling with its new high-pressure job, and to avoid anything that might increase pulmonary vascular resistance. The whole goal is just to keep the baby stable enough to get to a corrective procedure, whether that's a balloon septostomy to create a bigger mixing hole or the definitive arterial switch operation.
Okay, let's fast forward a few years. Now we're taking care of a patient who has what we call a single ventricle heart, and they've already had several palliative surgeries that have resulted in a Fontan circulation. Now, this is not a cured patient. This is a palliated patient with an incredibly fragile and totally unique physiology. It is so important to understand that this is a completely different world than a normal two-ventricle heart.
What is so unique and honestly kind of mind-bending about the Fontan circulation is that there is no right ventricle pumping blood to the lungs. I'll say that again. There is no pump for the lungs. The systemic venous blood from the body flows directly and passively into the pulmonary arteries. Just imagine a lazy river flowing gently downhill. That's the pulmonary circulation. The cardiac output from the one good ventricle is entirely dependent on how much blood can make it through that lazy river. So anything that obstructs that flow, anything that acts like a dam, is going to cause the whole system to back up and the cardiac output to just plummet. And for us, that dam is any increase in pulmonary vascular resistance.
So our anesthetic management for a Fontan patient is really governed by a set of sacred Fontan commandments. First, thou shalt protect pulmonary blood flow. That means keeping the patient spontaneously breathing if you possibly can. Positive pressure ventilation is the enemy of Fontan flow. Second, thou shalt optimize the single ventricle. These patients are so preload dependent, and they absolutely cannot tolerate arrhythmias. But the third and most important commandment is this: thou shalt keep pulmonary vascular resistance low, low, low. You have to avoid hypoxia, hypercarbia, acidosis, high PEEP, anything at all that could constrict those pulmonary vessels and stop that lazy river from flowing. All right, now it's time to put everything we've learned together. We're going to do a deep dive on one of the most challenging single ventricle lesions you will ever come across: hypoplastic left heart syndrome, or HLHS. This diagnosis is going to require us to integrate every single concept we've talked about so far.
You're going to see a summary sentence in an echo report that looks just like this. And it's a real mouthful, but let's unpack it together piece by piece. Mitral and aortic atresia means the left-sided valves are basically sealed shut. They just never formed. Diminutive LV means there's pretty much no functional left ventricle. Hypoplastic ascending aorta means the aorta is tiny. So you're thinking, how does this baby even survive? Well, that final part of the sentence is the key. Systemic output is ductal dependent. The right ventricle is doing all the work, pumping blood into the pulmonary artery, which then crosses over the PDA to supply the entire body. It's one single ventricle powering two circulations at the same time.
A child born with HLHS will go on this absolutely heroic three-stage surgical journey. The first stage, the Norwood procedure, happens in the first week of life. It's one of the highest risk operations there is. The surgeon literally builds a new aorta out of the pulmonary artery and then places a tiny artificial tube, a shunt, to give a controlled, restricted source of blood flow to the lungs. The second stage, around 6 months, is the bidirectional Glenn. Here, they disconnect the superior vena cava from the heart and just plummet directly to the pulmonary arteries. This offloads about half the venous return from that overworked single ventricle. Then, finally, a few years later, the Fontan procedure does the same thing for the inferior vena cava, completing that Fontan circulation we just talked about. And you can encounter these patients at any point along this incredible timeline.
Okay, so managing a post-Norwood patient, it's like walking a tightrope over a canyon. That one single right ventricle is pumping blood to both the body through the new aorta and to the lungs through that tiny fixed shunt. The way that blood flow gets distributed is completely dependent on the balance of SVR and PVR. If the PVR drops too much, say you give too much oxygen, blood will flood the lungs, stealing flow from the body and causing devastating hypotension and coronary ischemia. But if the SVR drops, blood will bypass that little shunt and go to the body, causing severe hypoxia. Our job is to stay perfectly balanced on that tightrope, using our ventilator and our drugs to keep the saturations in this delicate little sweet spot, usually around 75 to 85%. And all the while, we are constantly obsessively vigilant for shunt thrombosis, which is a catastrophic, life-ending emergency.
Wow. Okay, we have covered a massive amount of ground today. So let's bring it all home. What are the absolute most important things you need to remember when you're faced with your next complex case and that echo report is sitting in your hand? If you take away only one single thing from this entire explainer, please let it be this:
Situs is your North Star. Before you even think about a valve, before you glance at a gradient, before you consider function, you find the situs. It is the fundamental anatomical roadmap that gives context and meaning to every other single finding in that report.
And here are your 4 key action items. 1. Have a system. Use that 10-step framework every single time to build your mental model. Don't freelance. 2. Connect the dots between anatomy and physiology. For every structure the report describes, ask yourself, okay, so how does this change the path of blood flow? 3. Let the physiology write your anesthetic plan. Your plan has to be a direct response to their unique circulation. And 4. Anticipate the crisis. That echo report is your crystal ball. It tells you exactly what disasters can happen to your patient. Use it to predict and prepare for every potential catastrophe before you even walk into that room.
So the next time you pick up that echo report, you are going to know exactly where to start. You have a framework, you understand the core principles, and you know how to translate that data into a confident, proactive, and safe anesthetic. You'll know that your very first point of focus is finding your North Star, creating that fundamental roadmap. Now go out there and make a difference.